The QUO Podcast. Change your way.
Welcome to the QUO Podcast. I'm Ali. Professor Catherine Kevin is an academic at Flinders University, specialising in Australian and feminist histories and the politics and experience of the reproductive body. She is a founding member of the South Australian Abortion Action Coalition, a group that has campaigned since 2015 to decriminalise abortion in South Australia and to achieve access to affordable abortions for all, regardless of an individual's location. On March the 2nd this year, the Termination of Pregnancy Bill was passed, which made South Australia the final state to decriminalise abortion. As a long-term advocate in this area, how did you feel having this milestone achieved?
It was pretty fantastic, Ali. The campaign in South Australia, this campaign, and it's not the first campaign to be tried, has been going for 5 years. And it was really wonderful to have the bill finally passed by both parliaments. It's not the perfect bill, but it's definitely a bill that we can live with. And we did sit through some pretty unedifying parliamentary debate. But in the end, I think the amendments that were passed are amendments that we can work with. So, our job is not yet done, but this does open a way for much more equitably accessible abortion care in South Australia.
Couldn't you speak a little about the amendments that were made and why you feel they were problematic?
The law has now changed so that up until 22 weeks and 6 days, an abortion patient doesn't need to explain their reasons for having an abortion, and unlike previously, they are the person who will be consenting to the procedure. Previously, 2 doctors had to assess a patient's need for an abortion and sign off on that abortion in order for the abortion to lawfully take place. Our campaign was always to make abortion care healthcare, just to remove it from the Crimes Consolidation Act completely and to allow it to be regulated like any other form of healthcare. Abortion will not be delivered in a policy or regulatory vacuum. All of our healthcare procedures, as you know, require, informed consent, and they are delivered in the context of a framework that seeks to ensure quality of care, that seeks to be respectful to patients and healthcare providers, all of those things that we value in a good healthcare system. Abortion will be delivered in that same context. So as far as our campaign was concerned, we argued that there was no need for any extra regulation that would exceptionalise abortion as a form of healthcare. So the amendments that have gone into the law that will when it's passed, that are in the bill, has been passed, when it becomes implemented, they are really, I think, arguably very unnecessary.
You kept on talking about our campaign, so I'd love to talk a little bit about the organisation you're a part of, South Australian Abortion Action Coalition. Can you tell me about your work with them, their work, and what they do to help improve access to abortion in South Australia, especially in rural areas?
Our group began, the prelude to the group was a flash mob in, I think, about 2013. There was a national movement then that was started by Reproductive Choice Australia in Melbourne, and so there were flash mobs all around the country that were about ending the stigma of abortion, basically. So a bunch of us got together and we danced on North Terrace to Florence and the Machine, and we all wore T-shirts saying "End the Stigma." It was fabulous fun. Not too long after that, maybe I think about a year or so after, maybe a bit more than that, there was a conference which brought together practitioners and scholars of abortion in South Australia. And then soon after that, so in 2015, the South Australian Abortion Action coalition was formed, and I suppose the core group at that starting point had done the flash mob, had been part of the conference, and then decided, right, now is the time to start our campaign to change the law. We knew from the start that it was not going to happen quickly. In fact, one of our conveners said just on Friday night when we had our big celebration of the change that she had always thought it would take 5 years, and it took almost exactly 5 years.
Now that the Termination of Pregnancy Bill has been passed, is your focusing, is it more to do with rural, people in rural areas accessing abortions? Is that your current focus?
Yeah, well, look, I have to admit we haven't started that work yet, but we're all kind of talking about what the next step is. I suppose what we're acutely aware of, Ali, is that there is always a gap between the law and what happens on the ground. And one of the things that I haven't mentioned is that in South Australia, our abortion services are free. And that's not true of any other state or territory in this country. And so, not only is there a very high quality, dedicated centre for providing abortion services in Adelaide, where there is low staff turnover. It's a kind of national centre for training doctors and nurses and social workers in this space. It really is a kind of best practice model. If we look nationally at all the services, I think our service really stands out. Not only is it a great service, but it's free. It is paid for by the public health system. In other states and territories where the law changed quite a while ago, that's not the case. So while South Australia's been the last place to decriminalise, in cities like Melbourne and Sydney, you can pay a lot of money to get access to your abortion. And in places like Tasmania, women have had to travel to the mainland in order to get access to an abortion, and they've had to do it at a huge expense. So there's always, there is so often this gap between the law and actually people's experiences.
So, Kath, there's a strong intersection between your research as a historian and your advocacy work. You wrote about, in 2014, Fred Nile's Christian Democratic Party proposed a new bill called Zoes Law to give legal personhood to a fetus. So what were the possible implications of this law in terms of access to legal abortions?
The thing about discourses of abortion is that those who oppose access to abortion have, broadly speaking, two strategies. One strategy, and perhaps the oldest strategy, is to emphasise the value of the fetus and to portray the fetus as a child so that abortion can be then understood as a form of murder. The other strategy that they have is to say that abortion is very bad for women. Yeah, so those are the two strategies now. It's bad for women, it's unsafe for them psychologically and also physically. So I have been interested in the history of miscarriage, and I think it's always really important to think about things like miscarriage and abortion historically, because I think the meaning of these acts and these experiences is always socially and politically and culturally and therefore historically contingent. Prior to abortion becoming lawful, we know that many women sought abortions, lost their lives, were very badly injured by them. But many women also successfully sought abortions or performed abortions on themselves, and this is how they managed their fertility. In the age of sort of liberalisation of abortion laws, we get this growing focus and capacity to sort of visualise in a very detailed way what the fetus is, how it's growing. We discover the sex of the fetus. We start to think about, all the ways in which we might plan in response to the features of the fetus. It just gets a whole lot more. Our conceptualizations become increasingly detailed. So I think that has given the anti-abortion movement a great deal of ammunition. Of course, it's complicated. Like, we're in a period where risky wanted pregnancies can be much more easily protected, where premature babies can survive and give, parents a great deal of joy. So it's not, obviously, these things are both good and bad. But I think that all of that sort of elaboration of the fetus through these technologies and through the intensification of antenatal care has also fed into a discourse around the value of the fetus. What Zoe's law sought to do was to invest the fetus with legal subjecthood so that the fetus could be treated as a separate subject of the law. Now, the risk there is that you could have two competing legal subjects. So in the case of the loss of Zoe to her mother, Brodie Donegan, at 32 weeks, it's a very tragic set of circumstances. And of course, along with thousands of other people, I felt an incredible sympathy for Zoe's mother, Brodie. It was a very tragic event in her life. But, what the law, of course, does is it creates a set of definitions that can be applied in a whole range of circumstances. Now, in Australia, the fetus has always been, that has not had legal personhood. Legal personhood begins at birth. And that has made Australian law distinct from, say, US law for a very long time. And Zoe's law, had it passed, would have changed that.
Your research also focuses on reproductive coercion. Can you explain what reproductive coercion is?
Look, reproductive coercion is actually, particularly in the Australian context, is a fairly new idea. And it's something that there is currently a debate about, whether or not actually coercion or coerced control should be incorporated into legal definitions of, domestic and family violence or domestic and family abuse. Reproductive coercion is part of that coercive control. That's not the end of the story, though. So in my mind, there are two forms of reproductive coercion. On the one hand, you have reproductive coercion in intimate relationships, but it can also occur, say, in extended families. So, reproductive coercion can be perpetrated by parents and parents-in-law, for example, or a partner's parent, but also, of course, an intimate partner. So what we're talking about there is basically interfering in a pregnant person's agency about the outcome of their pregnancy, or indeed interfering in a sexually active person's capacity to control their fertility. So an example would be an intimate partner refusing to allow somebody to have access to contraception, or perhaps taking a condom off at the last minute, or refusing to allow an intimate partner to have access to an abortion, or it could mean forcing somebody to have an abortion. But I'm also interested in the way that we could argue the state perpetrates reproductive coercion. And one particular example that I've written about in the case of asylum seekers and refugee women in Nauru. And there was a case particularly of a woman called Abian, or that was the name she was given by the press, that was a pseudonym, who in 2014 was living on Nauru. She was actually, she'd been found to be a refugee, so she was no longer living in detention, but she was living in Australian government-sponsored housing on the island of Nauru in the community, and Abian had allegedly been raped. She was from Somalia, and she had lost her family during civil conflict, and she indicated, I think, that she had experienced sexual violence before she left Somalia, and then she arrived at Christmas Island. She had come probably via Indonesia, I think, and was sent straight to Nauru. She spent some time in detention. She was found to be a genuine refugee. It was when she was living in the community that she was raped. She became pregnant, and she had been, according to her lawyer, she had been begging the authorities to allow her to go to the mainland to access an abortion, because it is illegal to have an abortion on the island of Nauru. And eventually she did go to Sydney to access that abortion, and she was there for a very short period of time and was sent back to Nauru without actually getting the abortion. And the Australian government represented the story as her having just changed her mind. She got to Sydney, and she decided, actually, I don't really want to have this abortion after all. Now, she wrote a letter which was then given to the media by her lawyer, which actually described why she had not had that abortion, which was because she wanted some counselling, she wanted a translator, she wanted to get some proper care, she wanted to feel like she was having this termination in the context of appropriate care for her, where she would understand what she was agreeing to and she would understand what the procedure entailed. And while she was making those demands, she was waiting for something to happen. None of that materialised, and then she was put on a plane and sent back to Nauru. So I found this case very distressing and concerning, particularly because I had also been reading about women who had been taken under armed guard from Nauru to Melbourne. And there's a social work academic called Liz Hayes, who's also worked in abortion services, and she has published on this particular cohort of patients who were coming, and her work argues they were coming very frequently, from Nauru to Melbourne to have abortions. But the reason why Abiyan couldn't get access to abortion like those other women were in frequent numbers or in high numbers was because in the interim between that cohort and Abiyan, there had been 3 women who had sought injunctions to stay in Australia when they'd come to the mainland for their abortion. So the government just cancelled all access. So I just thought this was very interesting in terms of where the Australian government's investments were. They weren't invested in the women in Nauru having their babies because they were just, a more resource-intensive population. But at the same time, they then weren't prepared to take the risk of those women seeking injunctions to stay in Australia. So they weren't prepared to give women the reproductive freedom, delimited by their context, that they were seeking through abortion if it risked them seeking an injunction to stay on the Australian mainland.
Given that Australia has now decriminalised abortion in every state, what do you think some of the most pressing issues around reproductive health are?
It would be great if we could get more public health support for abortion services. So I think that we need to go back to the Labor Party's policy that they took to the last election, which was to provide public health provision of abortion in every jurisdiction. I think that would be fantastic. I also think we need to increase medical professionals' awareness of abortion and increase the provision of training for medical professionals as well, because a lot of doctors go through their degrees without really learning very much about abortion at all, let alone considering that this might be part of their kind of healthcare repertoire. I think it's really important that doctors understand what early medication abortion is, so that even if they don't want to be involved in providing surgical abortion, particularly GPs understand that there is this medication that people can take up to 9 weeks in pregnancy. It's very safe, but they need to do a very short online training course in order to become prescribers, and that this, I think if there was more awareness of that and we could get more doctors on board for that, then that would really enhance people's access to abortion. I also think that in relation to abortion, I suppose enabling more healthcare professionals who are not necessarily doctors to be able to also provide early medication abortion with, those who are adequately trained. I don't see why, for example, clinical nurses couldn't be trained to provide early medication abortion. And for people, especially people living in remote Australia, I think that would really make a big difference to their access. So creating as much free abortion provision as possible, and also increasing the capacity of healthcare services in terms of personnel to provide quality abortion care. I think there is still a stigma attached to abortion. I think we really need to work on that as a culture. I think decriminalisation is a huge step towards removing the stigma, but I think there's more work to do. It needs to be part of sex education. It needs to be normalised.
Thank you so much for taking the time to talk to me today, Kath.
My pleasure. I've enjoyed it. Thanks, Ali.